First, I want to give a big compliment to John arranging these sessions. They are nicely connected with each other. From the first session, you see the combination or linking between Medicare, American Community Survey, electronic health records, and all the other data sources, IRS, the administrative data site. And my talk and actually our U1 is nicely connected to this data combination, integration, or linking. And we focus on surveillance infrastructure building, but our methods can be generalized to the general data integration. So this is our team. Some of them are in the back. It is a group of statisticians, clinical, clinicians, epidemiologists, and computer scientists or programmers. So this is mainly a team effort. We have 4 aims, and our goal is to use existing data sources to build up a surveillance infrastructure, not just for COVID or for potential future pandemic. Our aim one is trying to build a stable or robust surveillance model for the small areas. So we look at county or demographic group level estimation. And then for aim two, we try to look into the health disparity in terms of COVID infection outcomes. So we will show you guys some results in terms of the infection outcome differences between demographic groups. Then for aim three, we implement our proposed methods into an interface for public use. And that is where you can try our interface to combine multiple data sources. And the aim four is a case study showing how to integrate electronic health records with survey data. We are in the building of the Institute for Social Research. We care a lot about population representation using survey, and even we are doing the data linkage or integration, but surveys are still playing an irreplaceable role to achieve population generalizability or representation. So I don't need to emphasize more about the importance of building a infrastructure for surveillance. So we care about population representation. That is the focus or the foundation of our U1 project. We want to make sure our results are generalizable and transportable to different groups. And then at the same time, you want this interface to be reliable, accurate, so that we can predict potential clinical and societal burden to prepare enough hospital equipments for the potential increase of ED visits or hospitalization, for example. At the same time, we can identify the population groups that are subject to high risk and need further attention. And then we can assess the efforts for as the response to the pandemic. So in terms of the current data sources for surveillance data, we have probability sample surveys. Traditionally, they are the gold standard for surveillance or population representation. However, during COVID, there is no probability sample implemented in the US to estimate the infection or the immunity prevalence. We have many surveys that have added COVID supplements. So for example, the house and retirement study in this building, they have COVID modules. They happen to have their data collection during the pandemic. And however, for probability samples, the main challenges come from the low response rates. as well as high raising costs. So how can we keep the gold standard of the probability survey as a high quality data source? That has been a challenging we aim to address for many of my colleagues in this building especially. At the same time, we have non-probability samples. So I'm using non-probability samples to refer to the data sources that are not collected via a probability sample design. So it can include the administrative records like the IRS tax records or the electronic health records or the Medicare, Medicaid claims data. So we have seen many failures or successes using either data source. However, the final conclusion is that a single data source cannot address the research needs or the policy goal we have in mind. We have to combine multiple data sources to build up a modernized surveillance data landscape. So this is the background. And then I want to show you guys the example of blending the electronic health records with a probability sample. So during COVID, we have built up a proxy for synthetic random sample to check or track the COVID infection prevalence over time. So we rely on the hospital routine testing records. If you have a surgery appointment with the hospital system, then you were required to take the COVID test at one of the designated labs of the hospital. So we gather those COVID test records, and then we adjust them by combining the EHR data with a probability sample. Here, we use the American Community Survey to get the population distribution of demographics. So we have age, sex, race, and their geographic information so we can get their target population distribution. And we combine these two data sources using an approach called Mr. P, multi-level regression and post-replication. That's our interface implementation, but it is just one of the methods for data integration. So how can you adjust the selection bias of the EHR data using a probability sample? You can use various approaches, but Mr. P has been shown to be an effective one in terms of small area estimation. If you are particularly looking at subgroups or the groups that need special attention, Mr. P can give you stable estimates comparing to weighting or other calibration approaches. However, Mr. P can fail as well. All the other adjustment methods or data integration can also fail. We have been using the American Community Survey to adjust the demographic distribution of the EHR data. But then based on the talks, we have seen health utilization or health status or comorbidity status of the patients who have surgery appointments could also affect their potential COVID infection outcome. So then what is the scenario that it can work and what are the cases it will fail? So from the statistical perspective, the success of these data integration cases depends on the quality of each data source. And to be specific, it depends on the common support of variables that are collected in both data sources. So for the EHR, we have demographics, and then we can get the demographic population distribution from the American Community Survey. But if we try to adjust for example, the house utilization measure, we get that from the EHR, but we don't have that population distribution from the American Community Survey. So that could lead to a potential failure of this adjustment. We need highly predictive variables. When I say predictive, they have to be predictive of both the outcome of interest, COVID infection, for example, as well as the inclusion or selection bias or mechanism into this EHR or the non-probability sample. So if you don't have those highly predictive variables, the adjustment won't work. So I just want to reiterate our case study with the routine hospital test data. We assume that the patients get the COVID test because of the surgery appointments. It is independent of their potential COVID outcome. So we rely on the asymptomatic patients. And then it's interesting that when they get their COVID test, we still have a large number of individuals who have positive results. So we'll adjust those positivity using Mr. P, assuming that they can track the underlying trends of the COVID infection rather than the magnitudes. So we have strong assumptions in terms of this adjustment. So we assume that if we adjust for socio-demographics or demographics, and we can track the trend, and the ratio between the asymptomatic and the symptomatic patients would be a constant within a uniform demographic distribution. So if we look at female who are younger than 18 white, and that ratio, the asymptomatic to symptomatic ratio is a constant. And this is a strong assumption, and we may fail this validation if we don't have additional data set. However, during COVID, because we need a rapid surveillance infrastructure, so we were using demographic adjustment purely to give a bounded estimates. But now when we go back, we have been checking whether this assumption is reasonable. So just to give you the brief background of Mr. P, is that we build a model using the hospital test records, and then we calibrate or adjust their representation using the American Community Survey. And we have their addresses, so we use the zip code to link to the American Community Survey. But for the interface, this is more general. You can analyze your own data sets with your specific target population, which may be different from the American Community Survey. That's why we are saying it is a general data integration tool. So to give you the idea of the adjustment, so we have found that only adjusting demographics is not sufficient. I don't know whether you guys can see this. After adjusting demographics of the symptomatic and asymptomatic patients, we still see health disparity in terms of their COVID infection outcomes. And the underlying interpretation of this disparity is social, not biological. That's why we want to adjust more potential confounders. So this is a general question or concern of data integration. How would you handle potential confounders? How can we obtain the population distribution of those potential confounders? And what about another data source that has the same outcome measure? When I say the same, like for COVID infection, rather than COVID test, you can also have your self-reported COVID results, but there could be heterogeneity in terms of the constructs. So for example, if we look at the electronic health records, we have their demographics, the geographic identifier, we have their test results, and our target population is the individuals who live in the catchment areas. However, if we look at the COVID module of the HRS 2020, and you can see that their assessment of COVID outcome is different. And their target population, of course, is different. So how can we integrate these two data sources in terms of the selection bias adjustment or the general data harmonization issue when we have to consider both the selection bias and the measurement error. So their outcome constructs are very different from each other. So our group has been working very hard to develop robust statistical methods to handle those different sources of error, and then you guys can run them through our interface. At the same time, we also have to be cautious about the data privacy or confidentiality protection of the electronic health records, for example. And then we want to make sure this interface is well maintained to address all the potential concerns. And here is the list of the papers our team has written, and I welcome any questions.